Hey friends, welcome back to the journal feed. My name is Nick Zelt. All right, here's the audio version of the past week's summaries, which this week were brought to you by our lovely authors, Aaron Lacey, Katam Patel, Matthew Starr, Doug Wallace, Megan Hilbert, and Clay Smith. Okay, let's go straight to the third article, titled The Prognostic Value of GFAP and UCH-L1, Biomarkers in High-Risk Mild Traumatic Brain Injury, a prospective longitudinal study of short and long-term outcomes out of the American Journal of Emergency Medicine. Now, over the last couple of years, we've been developing these biomarkers for whether or not you have an intracranial hemorrhage. Of course, now we're sort of indication creeping and trying to use them as a troponin for the brain. And I'm much more interested in them as a troponin for the brain. Forget bleeding. I don't think it's ever going to be that useful for bleeding. But I want to know how many brain cells are dying and how many is too many. And then I actually only want to know if we can do something about it. Is there a threshold for positivity on these that they benefit from, rehab for post-concussion symptoms or something like that? That's what I'd really like to know. I have not seen anything that's very convincing that makes me want to order these instead of just getting a plain CT of the head. Now, I know that not everywhere has the option to do CT imaging of these patients, and so it might be useful in a more rural setting. However, I'm not thinking that these companies are trying to market to rural environments per se, so they're going to try to get them into the mainstream everywhere hospital first, and I'm just not seeing good enough numbers. But let's look at these numbers. This was a prospective trial that had patients who came in with mild TBI, so they at least had a GCS of 13, and they had to be an adult, and they had to be prescribed a blood thinner, so still high-risk patients, but clinically quite well. Now, when they came in the door, they had these blood tests done, the GFAP and UCH-L1, and they had a CT of their head up front. And then they had another CT in 6 hours. No matter how they looked, no matter what the first one showed, they did another CT in 6 hours. This is because the authors wanted to evaluate whether or not these biomarkers would be good at predicting delayed bleeds. Now, you could argue that this is going to be very difficult for them to show. You need a huge sample size. The rates of delayed bleeds, we're looking at maybe 1%-ish in this sample and just generally. So there's not a lot of delayed bleeds that you're going to see in these populations, particularly not ones with a good GCS. All right, so how did this turn out? Well, if you combined both of the biomarkers, then you get sensitivities 96%, a negative predictive value 96%, not that bad. Terrible specificity 24%. You got negative likelihood ratios here in the teens, which is not bad, but it's also not amazing. They also followed up these patients to see if they had symptoms, post-concussive symptoms at 3 months and 6 months, and a third of the patients had those symptoms at 3 months. And about half of the patients had it at 6 months, but I'm sure there was some reporting bias there because if you have no more symptoms, you're probably less likely to answer their call. Now, what about saving delayed scans? Well, only about 1% of these people had delayed bleeds, and that's only 3 people. So I'm not going to draw any conclusions from that, even though they do report the numbers. A sensitivity of 100% on 3 patients, not that useful. And on top of it, I don't necessarily want to know which patients just bled. What I want to know is clinically significant head traumas. Who's going to need a neurosurgical intervention? Who might die? Who's going to deteriorate? These are the things that I want to know, not just who has some blood on their CT, because we know a significant proportion of patients that have some blood on CT, again, you're not really going to care that much if it's just a tiny bleed. If they're, brain injury guidelines big 1, then whoop-de-doo, that patient's still going home. And we don't necessarily have those numbers from this sample. I think a lot more work needs to be done before these tests are going to be clinically relevant. But frankly, with the numbers that we're getting so far, I don't think that these tests specifically are ever going to be clinically relevant. Even if you're in a rural setting, and then you start reflexively ordering these tests, now I think there's a lot more of these patients who might screen positive and then be sent somewhere to get a CT of their head, when just from a clinical evaluation, you'd probably be able to conclude that, hey, they're going to be just fine. I would need to see practical studies that actually compare those two things in a rural environment before I would even dream of considering actually implementing something like this in those settings. In an urban environment, I think you're better off just getting the CT of the head when you need to. In a spoonful, these tests continue to be shown in a positive light, and their test characteristics are not that bad, but to me, I just don't think they qualify as good medicine just yet. Okay, then the fourth article titled Efficacy of Adding Intravenous Saline Solution to Non-Steroidal Anti-Inflammatory Drug-Based Treatment of Acute Migraine in the Emergency Department out of the Annals of Emergency Medicine. Okay, so I think it used to be pretty common that most people's quote-unquote migraine cocktails, which a lot of people hate on, but I don't dislike that much. I think most people kind of have a strategy of medications that they give for various things, and for whatever reason for migraines, we call it a migraine cocktail. Now, I'm not a huge fan necessarily of the connotations with alcohol and all that, but hey, I'm not that against it. I don't even drink, and it's still okay with me. That said, gets a lot of hate. But regardless, let's have a look at this component, which I think is pretty commonly used in migraine cocktails, which is usually a liter of normal saline. Now, there have been previous studies which have shown that this probably isn't doing anything, probably isn't helpful at all. However, those studies were done in combination with other drugs and not NSAIDs. And NSAIDs are pretty commonly used for migraine treatments in the emergency department. They actually work quite well. Personally, I give IV ketorolac. This study used 75 milligrams of IM diclofenac. Both are probably good. Now, of course, other agents like prochlorperazine or metoclopramide are also great, and that's what it's been tested against in the past. However, let's do it now in an NSAID population. Personally, honestly, I just give both, but one at a time is fine too. All right, so this was a single center RCT on 125 patients who were randomized to get a bolus of 1 liter or not with an IM diclofenac. And the primary outcome was pain scores on a visual analog scale at 2 hours. And though there was numerically a difference, there was not statistically or clinically a difference between the two groups. And so we see that 1 liter of normal saline probably isn't being very helpful for the pain that you're having as a result of your migraine. Now, of course, I'm not going to say that you should never give it. If the patient's been throwing up for hours and they look like they could use some hydration, then great. I say go for it. But if it's just part of your standard cocktail, then save the nurses some trouble, free up a space where they would need to have this drip going, just boom, give them those medications back to the waiting room, see them in an hour and a half, 2 hours, and see if they can go home. Rescue medication use was lower in the fluid group, 24% versus 42%, and ED length of stay was moderately shorter. So overall, it doesn't seem like you're wasting that much time, but you're probably also not doing that much good with a liter of saline. So take your pick if you want to keep it in your cocktail or not, but you're probably not making their pain that much better. In a spoonful, this study fits with the previous evidence and is pretty high quality in RCT. That seems like giving a liter of fluid along with your treatment for migraines is not terribly effective. Okay, that's all the articles from this week. Let's do a quick wrap up. And from the third article, I'm hoping that these TBI biomarkers don't make it to primetime anytime soon. They're not performing that badly, but I don't think they're performing good enough. Then from the fourth article, fluids seem to have no empiric place in the migraine cocktail. All right, if you are hearing this right now, then you're not a part of the members feed and you missed 3 articles that we reviewed from this past week. One was talking about whether it's better to use VL or DL during cardiac arrest. Another was whether or not it's useful to do a platelet transfusion in patients with TBIs. And then finally, 10-year follow-up on antibiotics versus appendectomies. Something you might want to know. Links to all the original articles can be found at journalfeed.org or just follow the links in your show notes. Our goal here is for you to keep up the easy way through spoon feeding. Thank you.